we are welcome. I want to introduce the presenter to us tonight, somebody that is well able to handle the topic that is before us, which is combating cervical cancer burden, the role of clinical pharmacist. The presenter is nobody but from Asishana Temitope Kemi. She has B Farm, FCC Farm in view. She is an oncology pharmacist in University of Ilorin Teaching Hospital. She is also a member of International Society of Oncology Pharmacy Practitioners, that is ISOP. She is currently on Certificate on Oncology Pharmacare, Introduction to Cancer Treatment, Leadership and Management in Health. She is a competent person to handle the presentation tonight. And also, I believe that this is a presentation that a female will be very suitable as the presenter. By this, I want you to join hand with me to welcome Farm Ashishana Temitope Kemi. Let us welcome her with a round of applause. Meanwhile, electronic round of applause. You can clap at your hand, you can clap. But let us welcome Farm Ashishana Temitope to the floor to handle the mic for tonight's presentation. Thank you, Farm Ashishana Temitope.
Yes, thank you very much. Yes, thank you very much, sir. And I want to greet everyone. Good evening, sirs and ma, and to the chairperson of CPAN. I welcome everyone. I want to say good evening to everyone once again. And I want to thank the organizers of this educative program. Thank you for the opportunity to present this crucial topic at this moment. I really, really appreciate the opportunity and the privilege given to me. So without wasting much time, I'll be sharing my slide now to do the presentation. Okay. So just 1 more minute. I want to. Okay, please, can we see my slide?
Yes,
yes, we can see it. Yes, it's visible.
Click on slideshow. Click on slideshow.
Okay, can we see the full screen now?
No, not yet.
No.
Click on slideshow. Yeah, okay.
Slideshow.
Yes, I think it's my. I'm coming. Okay, can we see the full slide now?
Yes.
Okay.
Yes, we can.
All right. Thank you very much. So, I'll be this evening, the topic before me is combating cervical cancer burden, the role of clinical pharmacists. I'm pharmacist Asishana Temitope Kemi at and I work as a oncology pharmacist at the University of Lorraine Teaching Hospital. So this is the outline of my topic, the introduction, cervical cancer. We'll be looking at the overview, the etiology, the epidemiology, the risk factors, and clinical features. Then the diagnosis of cervical cancer, the prevention and treatment. We'll be looking at the vaccination, the screening programs, and treatment options that are available. Then our role as clinical pharmacists, what are our contributions to patient care, the advocacy, and then oncology pharmacy practice management. Then my conclusion. So cervical cancer is a type of cancer that starts in the cells of the cervix. As we know, cervical cancer is one of the cancers one of the types of cancers that are ravaging the world presently. And the malignancy is primarily caused by the persistent human papillomavirus infection. It poses a significant global health burden affecting women of different socioeconomic backgrounds from the age of 15 to 44 years. And this disease has a profound impact on women's health, both physically and sociologically. It affects women's health, and not only affecting women's health, it causes a lot of psychological issues for women. 90% of cervical cancer deaths occur in low to middle income countries because of limited accessibility to healthcare. We also, we also have poor infrastructures. We have limited facility. We have limited facility. Facilities with no much healthcare costs and economic burden on individual and then the society at large. And because of these collaborative approaches that have been put in place to combat this disease, the approaches involve vaccination coverage, enhancement of screening infrastructures, and then improved access to healthcare facilities in order to mitigate this cancer. And we as a clinical pharmacist, we play a very crucial role in enhancing patient safety and ensuring their adherence to their treatment plans and overall therapeutic efficacy. This plays a crucial role in the patient's outcome. And so we have a lot of role to play as pharmacists, to improve the healthcare to improve the health of patients that are fighting this disease. The next thing I'll be talking about is cervical cancer. We'll be looking at the overview of cervical cancer. So from this diagram, it shows the anatomy of the cervix. You can see that the cervical cancer is just a narrow just the narrow end from after the vagina to the uterus. It's just a narrow part there, and it consists of two major parts. That's the endocervix and also the ectocervix. So the exocervix, that's also the ectocervix, is part of the cervix that can be seen during that can be assessed during any gynecology examination, and it consists of flat and thin cells that are called squamous cells, while the endocervix is the inner part of the cervix that forms the canal to the uterus there. And so that part is also is covered with column-shaped glandular cells that produces mucus. So the border between the endocervix and the ectocervix is called the scamocular junction. And most cancers begin from this area. So this cervical cancer develops slowly. Most times some women carry it for a very long period of time and they don't even know they are having issues like that, because it appears like probably small changes in the cervix, and the small changes is referred to as dysplasia. And over time, if it's not removed or maybe destroyed, they start spreading, and then to the surrounding cervix and to also the surrounding areas of the cervix. So there are two types of cervical cancer. We have the squamous cell carcinoma. The squamous cell carcinoma. From this diagram here, we can see the thin cells here that I was trying to describe. That is called the thin cells, the squamous cell. So the cancer that develops from there is called the squamous cell carcinoma. So it develops from the ectocervix. And then the other type that we have is adenocarcinomas. That starts from the endocervix. The cervical adenocarcinoma develops in the glandular cells of the endocervix. For the etiology, the causative agent is the sexually transmitted but there are two types that are very they are termed as the IRIX type. That's the type 16 and the type 18. That's the type that causes 70% of most cancers that that we see worldwide. And nearly all people who are sexually active will become infected with HPV at one point of their life or the other. And most HPVs, infections, they go on their own. But when it stays longer than it's necessary, that's when it develops a precancerous lesion. And afterwards, if it's not removed, if that lesion is not removed, it develops finally to the cervical cancer to cervical cancer. For the epidemiology, presently, the new cases of cervical cancer worldwide is 604,000. And, this is attributed to nearly half of the number of people that are having this cervical cancer eventually, died. And the deaths worldwide is 342,000. And these figures were gotten from 36 countries, making it the cervical cancer the fourth leading cause of death among women. So cervical cancer is the fourth most frequently diagnosed cancer, and is mostly diagnosed cancer in 23 countries. A vast majority of these are found in the sub-Saharan Africa, Melanesia, South America, Southeastern Asia. And the highest region of incidence and mortality is seen in the sub-Saharan Africa, with rates elevated in Eastern Africa. Rates elevated in Eastern Eastern Africa, lower in the north. There's a table here, that shows the figures. The Southeastern Africa, you can see it's 54,560 for the incident, and then the death rate is 36,497. Then for the Middle Africa is 15,646, while for the death rates, we can see this is even more than half. In the Middle Africa, we have 10,572 deaths that result from as a result of the disease. So in Nigeria, cervical cancer is the second most common cancer in women from age 15 to 44. And as at 2023, we had 12,075 new cases were recorded and approximately 8,000 deaths, making cervical cancer mortality is higher in women who have not been screened in the last 5 years, and those women without consistent follow-up post-identification of a precancerous lesion. This figure is very high, and before in 2020, cervical cancer in Nigeria was rated third, but now it's rated second most common cancer. And so we need to step up our game as pharmacists, in creating this awareness that we are doing presently. So what are the risk factors of cervical cancer? The risk factors are immunosuppression, especially for people that have low immune system, for sexually active women, for women or children at age below 18, or if the person is having multiple sexual partners, they are at high risk of having cervical cancer. Smoking is also a risk factor. Obesity, reproductive factors like long-term use of contraceptive and too many baths, then exposures to diethylstilbestrol, which causes a kind of cancer, cervical cancer, called clear cell adenocarcinoma. Then if a person is having a family history of cervical cancer, the person who is at risk. Then race also, according to a study, that there are more of it in Africa, probably due to maybe early child marriage and issues like that. And yes, early child marriage also is a factor. What are the clinical features of cervical cancer? We have vaginal bleeding, unusual discharge from the vagina that has a foul smell, then pelvic pain, dyspareunia, postcoital bleeding, persistent pain in the back, in the legs and the pelvis. Then if the person is having weight loss, fatigue, and loss of appetite, there are clinical features that can, warrant tests to detect if the person is
Hello, we can't hear anything. No. Who is the moderator, please?
Hello, sir. I think we've lost the presenter. I guessed it was network from our end. I'm trying to reach her personally. I'm trying to reach her personally, but it's like the network on our end is somehow.
All right, let's wait more. I hope
Okay,
her
sir.
phone, her battery didn't go off.
Maybe we'll wait a bit.
Hello, I'm sorry, my network is fluctuating here. Can we all hear me now?
Yeah, we can hear you. You're welcome. You're welcome back. We can hear you.
Hello, can we?
Hello, Fantemi, we can hear you.
Okay, all right. I'll continue now. Yeah. Okay, sorry, I'm trying to share my
screen.
Okay. Just 1 minute. Okay. Can we see the full screen now?
Yes, we can. We can. Not the full screen.
Not the full screen.
Yeah.
I'm not doing anything, no. It's part of it.
Okay. Like this, can we see the full screen now?
Yeah, it's back. We can see it.
Okay. All right. So, pap smear, I said the other time, and HPV testing is the mainstay of cervical screening in hospitals. And 90% of most cases of cervical cancer are detected by pap smear and the HPV testing that are readily available. And then HPV testing is done every 5 years. Then you can do both, that's the HPV and the pap co-test every 5 years, or you can the pap test can. Then another method of diagnosis is endocervical curettage, then colposcopy and biopsy. So this diagram of cervical sampling that was being done, that the way it's being done here, they use a speculum to is inserted into the vagina to widen it, and then the speculum has like a brush that collects sample from the cervix. So once the samples are collected, they are taken to the lab for tests. So for the pap smear, this can be used, and also the HPV tests. The HPV virus can also be tested via this method. So how can we prevent cervical cancer? In 2018, given the substantial global burden of cervical cancer, and the increasing inequality, the WHO director made a call for global action towards the elimination of cervical cancer, and this involves a triple intervention strategy. The intervention strategy is to vaccinate, to screen, and also to treat. So the vaccination basically is against the HPV 16 and 18. And it has been proven that 91.6, this vaccination has been proven to have 91.6% efficacy. And evidence is from randomized controlled trials and also from cohort studies. The vaccines that are being used that can be used are the Cervarix. The Cervarix is by GSK, is the bivalent HPV vaccine, but it protects against just the HPV 16 and 18, while the Gardasil is, we have the 9-valent and the quadrivalent HPV. Is also a product of Merck. On the 24th of October 2023, the National Primary Health and Care Development Agency, in support from Gavi, the Vaccine Alliance, and then the UNICEF and WHO, they launched the vaccine, the vaccine for cervical cancer. And this launch was to reach, the launching was done so as to reach 15 states in 2023. And then next year, that's 2024, 21 states will also be reached. For the first 15, they took two states from each geopolitical regions, with FCT included. And this is to at least vaccinate 90% of all girls by age 15. The other method of prevention is through screening. Screening of 70% of women twice in the age range of 35 to 45 years. Then the American Cancer Society recommends that screening should be done from age 25. Then every 5 years until the woman attains the age of 65. And this is where we can play our parts as clinical pharmacists in the vaccination and also in the screening aspect of method of preventing cervical cancer. Then we need to treating at least 90% of all precancerous lesions detected during screening is also very important in the prevention of cervical cancer. Then another method of prevention is through sexual abstinence, or if the person cannot abstain, they can use protective barrier through the use of condoms and the like to prevent the virus from being transmitted. In the treatment of cervical cancer is treated based on some factors, and that involves the staging, the overall health performance of the patient, then the goal of treatment, and then the treatment options that are possible and their possible side effects. So these are the factors that are being considered before treatment takes place. In the staging of the cancer, the staging is done by the Federation International of Gynecology and Obstetrics, and then the American Joint Committee on Cancer. So the stage cervical cancer based on cervical cancer is staged as stage 1, stage 2, stage 3, and 4, and there are different treatment options that can be used in all these stages. Then about the performance status, for every patient, there are patients that could be on maybe stage 4 of stage 4. You can't really treat. In cases like that, you have to palliate. Then they look at the goals of treatment. Is it cure? Is it control or palliative? Then the treatment options that are also available and their possible side effects. in the treatment of cervical cancer, surgery is being used. And when surgery is used, there are different methods, different strategies that are used. It could be total hysterectomy. The total hysterectomy is the total removal of the cervix and also the uterus. Then this can be done in the stage 1, because they would have considered several factors, and then so as to prevent any form of spread or metastasis. Then conization. In conization, they remove just a cone part of the cervix. Then if they are using radical trachelectomy, this involves removing parts of the of the cervix, and also the upper part of the vagina. So these are treatment options. These treatment options, they are used basically in stage 1 cervical cancer. Then another treatment option that can be used is radiation therapy. Another one is chemotherapy. And in the use of chemotherapy, they use anti-cancer cells, and we have different classes of these anti-cancer drugs. Sorry, I mean anti-cancer drugs. We have the cisplatin. They use basically the platin classes, and then the taxanes also. It involves the use of cisplatin, carboplatin, gemcitabine, paclitaxel. Then immunotherapy is also used, and targeted therapy. Then there's also need in treatment to follow up the patients and monitor them closely. So what's our role as clinical pharmacists? Our role as a clinical pharmacist in this burden of cervical cancer, we have a lot of roles to play in the treatment, in the screening of patients, and also in the vaccination of patients also. So our contributions to healthcare, to patient care. Our contribution as a clinical pharmacists, we need to practice what we have been trained on, and that's medication therapy management. So in medication therapy management, you gather the patient's information. After gathering the patient's information, you check for any possible drug therapy problem. In the process of you gathering the information, then you also make plans. You make plans on how to treat the patient. After making plans, you carry out your intervention and then document. Then it's also important, after all this process, you follow up your patients and you monitor them closely. Then if there are cases where you need to refer, you make referral also. It's very, very important. So the first point I have here is assess medication safety regarding therapeutic use. This all comes under medication therapy management. You assess the medication safety regarding therapeutic use, the pharmacokinetics, you look at the pharmacodynamics, the patient's specific characteristics, then tolerance and disease response during and after treatment. You are also looking out for, you also adjust those drug dose relative to the performance status of the patients. As pharmacists, we verify the potency of the drugs that are being administered, especially for the chemotherapeutic agents. Most of them, some have to be stored in certain conditions. Maybe they have to be in the fridge at a particular temperature. You make sure all those things have, the stability of the drug is assured. And the sterility before administration. As a clinical pharmacist working in the oncology space, there is also the aspect of reconstitution of all these chemotherapeutic agents. So we verify, and then we verify the potency, stability, and sterility of medications before their administration. We also verify prescription orders. We verify prescription orders. Like one of the drugs that are being used in the treatment of cervical cancer, like I said the other time, is the platins, the carboplatin. They are to be monitored closely. Then when the calculation is not based on the surface area, it's based on the area under curve. So all these things have to be, monitored closely. Then as our contribution to patient care, you ensure cost-effective medications for these patients. There's actually a program that is being run by the federal government, that's the NCAP, Cancer Access Partnership. They ensure that medications are given at a very cost-effective rate to patients. Then they also ensure the safe and appropriate medication use, because some of these patients, they go back home with the medications for the orals to make sure they are used at the right time to avoid issues of resistance. Then you evaluate the appropriateness of the anti-cancer therapy dose, the clinical indications, the eligibility for treatment. As pharmacists, when orders come like that for dispensing of such drugs, you look if the patient is fit for the treatment. Normally, for patients on chemotherapy, they have to do the full blood counts and some other tests before they are being administered. So you make sure that for the full blood count, the patient is eligible to take the treatment. Then it also facilitates medication adherence. You monitor drug for therapy adverse effects. That's for the pharmacovigilance related activities. Pharmacovigilance involves active reporting of any drug therapy adverse events. So you make sure that when a patient is undergoing any adverse event or side effects, is being reported immediately. Then you also empower patients with the right information. So as pharmacists, we should be armed with the right information at every point in time. And for each patient, it should be patient-specific education to each cancer patient that is undergoing treatment. Then our role also involves advocacy. We are to promote patient and caregiver advocacy by serving as a liaison for access to cancer care and also clinical trials. We should ensure easy access to secure medications for patients and family. We should also negotiate legislatively and negotiating legislative and regulatory matters, in cases where we have to, help patients to get good, affordable drugs, safe, affordable drugs. We should be able to negotiate in matters like that. Then interprofessional collaboration. As pharmacists, we should be clinical pharmacists in this aspect. We should also be part of the multidisciplinary team. Then collaborating and leading education programs that support cancer prevention and screening. We should also collaborate in vaccination programs. Like the pharmacists community pharmacists in the United States, they screen for cervical cancer and also administer HPV vaccines. We also, when we, lead programs that support cancer prevention, over time we can, and also, negotiate well in the legislative and regulatory matters, we can get to the point where, pharmacists can be licensed to also screen for cervical cancer and also administer the HPV vaccines. We can provide support to patients living with cancer through, the support groups, and then raise public awareness of cervical cancer and its management. We can also provide recommendations on lifestyle modifications, because this is very important. one of the risk factors of cervical cancer is obesity, smoking. So as pharmacists, we should be able to provide recommendations on this lifestyle modifications so that patients can live a healthy lifestyle. Then in the oncology pharmacy space, we should, just like I've said, we should be a member of the multidisciplinary team. We should create standard operating procedures and policies for oncology pharmacy practice, then contribute to the cervical cancer drug development and oncology research. One of our roles is, the management of these vaccines. The vaccines, they are cold chain products. So we should be able to manage them properly. Then promote safe handling of hazardous medications used in all clinical environments. We should also develop strategies to mitigate and manage and prevent medication errors, drug-related problems, and then drug-related morbidity. So here I have a case study of a pregnant woman that was diagnosed of differentiated squamous cell carcinoma of the cervix. So she had abnormal bleeding that was detected during a regular prenatal examination in the 15th gestational week, and a 2 cm cauliflower-like neoplasm was also found in her cervix. So when she did cervical biopsy, it suggested a poorly differentiated squamous cell carcinoma of the cervix, and HPV type 16 was also detected. It was positive and in the 21st gestational week. So she was commenced on neoadjuvant chemotherapy of paclitaxel and cisplatin regimen. The pregnant woman also had received a cesarean section in the 34th gestational week, during which she had radical after the cesarean section. And during this cesarean section, she had radical hysterectomy and pelvic lymphadenectomy. It was also performed, but metastasis was identified in the resected pelvic lymph nodes, and then an additional 35 sessions of radiotherapy. There was no cervical cancer cell was detected. So I want us to look at this case and determine what the role of the pharmacist is in this case scenario. First, the thing is that this woman is pregnant. So because of this, she can't take anyhow medication. And the treatment that was placed for her, the neoadjuvant chemotherapy, was paclitaxel and cisplatin regimen. So our role as pharmacists in this kind of case scenario is that we should look at the medications that are being given. Is it this type of drug? Will it cross the blood barrier, the blood placenta barrier that that can affect the baby? Will it cross the placenta barrier to the baby? Because, and then another thing is the stage at which the cycle was commenced also. Most times in the first trimester, it's not always recommended that any pregnant woman should undergo chemotherapy. The way the risk ratio to the benefits, if it involves terminating the pregnancy at that stage, they might have to. But now she has passed the first trimester. So that's why the paclitaxel and the cisplatin regimen was given. Then the other thing is that as a role, we should look at these medications if they are also pre-medicated, because most of these medications, they have their side effects, and cisplatin is a drug that is highly emetogenic. So they have to use the ondansetron and probably the placebo also in addition. So as pharmacists, we should look at all these regimens the drug and the regimen, the performance status. We should look at the performance status. If is she fit to take the chemotherapy. Then another thing is another role here is to educate this patient, because now she has to undergo a radical hysterectomy where the whole uterus and the cervix will be removed. There's the probability she won't be able to give birth again because there's no uterus to carry the baby. So we should be able to educate the woman on the process she's going to be undergoing. Then, another thing we should look at is the screening as pharmacists, the screening and vaccination of the baby that will be born. The option that was picked there for cesarean section is a very good one, because there won't be any issue of transmission of the HPV virus to the child. And so, but when the child grows a little, we should also educate the woman on making sure, if the child is female, to educate the child on making sure that a girl child is being vaccinated, because the pregnant woman already has there's already a family history of the cervical cancer. Then we should also ensure, this woman goes for screening. That should be part of our education. Undergo screening every 12 months or every 3 years. Now, because she was already detected initially of having cervical cancer, she has to go probably every 12 months for follow-up visits. So in conclusion, understanding the burden of cervical cancer, after having understood the burden of cervical cancer, there is need for collaborative efforts of healthcare teams to combat this disease. As pharmacists, we need to participate in programs that mitigate and reduce the incidence of HPV. We can see lately, there are so many instances and so many myths that the vaccine causes this, the vaccine does that. We should be able to educate the patients and also their relatives on what the vaccine is all about. It's also important to note that the training scope and skills of pharmacists have gone beyond just dispensing roles, and it involves their active involvement in essential care and management for patients. Therefore, government and various pharmacy administrative and regulatory bodies must begin to make accessible to pharmacists the necessary skill to allow them to contribute effectively and efficiently towards the prevention, the treatment, and elimination of cervical cancer. Pharmacists can be further educated and trained on more innovative approaches and actions to take towards cancer care. This will enable them to improve their relationship with patients and better improve the quality of health services. So these are my references. Thank you for listening. Thank you very much.
Thank thank you, Representative Tishana Kemi,
Thank you very much.
for the brilliant and wonderful presentation on the burden of cervical cancer, the role of clinical pharmacists.
Thank you
As a
very
form
much.
of a summary, before we go to the question and contributions tonight, we have been told about how cancer, cervical cancer, is actually becoming so common today, especially in our part of the world, the sub-Saharan Africa. Nigeria as a case, we see that cervical cancer is the second most common cancer disease in women. Please, so you can hear me. Am I audible? Hello, I hope you can hear me.
Yes, we can hear you, sir. I can hear you.
Okay. Thank you. So, from the presentation, the presenter showed us some of the common etiological and the risk factors. As we saw from the lecture, we see that the most common, the major common organism that is indicated in cervical cancer is human papilloma virus, which can be contacted through all form of sexual activity. And as a man said, if you are a woman and you have cervix, you can have cervical cancer. So knowledge of cervical cancer is very important for everyone. If you are not a woman, you will have a woman in your life as a sister, a wife, a mother, or anybody. As a pharmacist, the knowledge of what we are told tonight is very, very essential. We have seen the various risk factors such as sexual activities, promiscuous activities. We've seen the issue of chlamydia, trachomas, the issue of HPV virus, then risk factors such as smoking and other poor sexual hygiene. And she also talked about this common drug that people get over the cancer, that is diacetyl. Some of these chemists do see dispense it despite the risk in our society today. Then we talk about other signs and symptoms that we can see in a patient presenting with cervical cancer. We see postcoital bleeding, spontaneous bleeding, intramenstrual bleeding, and postmenopausal bleeding. All these are signs that we warrant a patient going for screening. And during the case of the treatment, she talked on prevention strategies, and we saw 3: vaccination, screening, and treatment. For the vaccination, we were told that 90% of all girls need to be vaccinated from the age of 15. And for screening should be done for all women from age 25 and should be done every 5 years. Then for the treatment depends on the stage of the cancer. The stage 1 can still go on surgery. Then other stages, we see radiation therapy, chemotherapy, immunotherapy. And for prevention, we can do every activity to prevent human papilloma virus, like abstinence, the use of condom, and some other method of prevention she mentioned. But specifically, let me briefly run through the role of clinical pharmacists. As she said it, we see medication therapy management. That is a particular role that pharmacy can be involved. You share the drug therapy of the patient, you assess medication safety, you verify the drug potency, verify prescription order, ensure cost-effective medication, ensure safe and appropriate medication, evaluate appropriateness of the anti-cancer therapy the patient is on and the dose. Then facilitate medication adherence, monitor drug therapy, adverse effects, empower patients with right information. She also talked about the advocacy measure. We promote patient and caregiver advocacy, involve in interprofessional collaboration. Also, she talked about the vaccination program that the clinical pharmacy can participate and be involved as it is done in advanced country. Now we talk about providing support to patients living with cancer as a role of pharmacist, provide recommendation on lifestyle modification, and also be involved in the stocking and the distribution of the vaccine, which is also a post-chain product, prevention of medication error and medication-related toxicity. So we saw the epidemiology and other things that have been said before. Before we go to the question and answer session, the issue of the vaccine, the vaccination has been generating some sort of discussion since the area of cancer, cervical cancer has been out, and part of which we want us to equally discuss tonight. Some people have that inertia, that unwillingness to go for vaccine because of what happened during the COVID-19 vaccination period of recent. So those are the things we still need to talk about tonight. If you have any question, anybody with question, please, you can do that by raising up your hand or drop your question in the chat box. Thank you. The first person we will permit, sir, is our national chairman, Dr. Joseph Madu. Please, sir, you have the floor.
Michelle.
Thank you, sir.
Okay, good evening. Good evening, everyone. Please, can you hear me clearly?
Yes, sir, we can hear you.
All right. Let me first of all thank the moderator, the presenter, for the great presentation she has made. And then I must thank the moderator himself too, for the summary of the presentation. Actually, I got more information listening to your summary. And most importantly, let me also commend the clinical oncology pharmacists of Nigeria. You are doing well, and may the good Lord continue to go before you in all that you do. All right. Please permit me to ask this question this way. I'm aware that it is said that if cancer, for instance, starts in the cervix and the cancer metastasizes, probably it goes to the breast or it goes to the lungs, it will no longer be called cervical cancer, of course. It will be breast cancer, or if it's in the lungs, it will be lung cancer, but actually it's originated from the cervix. Now, I have something I don't know if the presenter can throw light, or any other person in this on this platform tonight. I have someone I'm aware of who had cancer, and this cancer probably started as a cervical cancer, but this cancer later spread to the liver and then also the lungs. And this client has also undergone some surgical operations. Actually, when it got to the liver, it was a fearful scenario, but after surgery, the surgery was done in the United States, I think. After surgery, and after like 3 months or 6 months, cancer cells were not found anywhere. After a year or so, no cancer cells anywhere. And we continue to celebrate this client. But I think after like 2 years later or so, cancer was found again in the lungs. And this client also, or patient, went for surgery again. And then the something somehow disappeared. The client was also, I think, on chemotherapy or radiation therapy as well. This thing disappeared too. But after a year later again, the the cancer cells have been found again somewhere around the lungs, and there are different spots. Now, my question is, please, what advice can we give to this clients or patients? What advice can we? I believe this client has been on different measures. Yes, of course, there are a lot of things we know we tell cancer patients, or yes, to take maybe vitamin C, take their drugs, take other things that then avoid some other things. All this patient has been passing or taking all this or following all these measures. And now recently, the signs have been again in the lungs. That means this thing to disappear maybe after surgery or whatever, and then later appear again. I don't know if the presenter has any advice to give, or anyone on this platform has advice to give. I believe this question is not the scope of this presentation. Thank you very much.
Thank you, our national chairman. The presenter, please, you have the floor if you have any information to pass on what our chairman has asked.
Okay. All right, thank you very much. Now, for the cancer that was detected at first at the cervix, and then later, it spread to the lungs and to other parts. Like we all know that cancer is it's caused by different factors. It's caused by different part of the it is, and also the can metastasize to different parts of the body fast, especially when they are not well taken care of immediately, or maybe because they are not like for the cervical cancer. Most times before they detect, it would have spread before there's actual detection of the cancer, because the signs and symptoms might not come all at once. The person might be feeling just this way and might be feeling probably it's just an infection or this or that. And before, they actually go for tests, the thing would have spread. And that's one of the problems that we have in this part of the world. In middle to low income countries, there's no awareness, there are no screening facilities. So that has reduced the rate at which a patient can it has reduced early detection of cancers. So for a patient like that is going and reoccurring, probably the person has to look at other things, probably the food, the environment. Then another thing about this, it could be a gene factor. It could be a gene factor. I don't know, maybe other people have any other person has any contribution, but I think it's probably more of a gene factor, of all these mutagenic cells in the body. So for a situation like that, the person has to go for probably this genetic testing to see what is actually causing, to see if there are genes in the body that are already, I don't know how to put it, that are mutagenic. Then another thing is lifestyle modification. Lifestyle modification, like I've said earlier, if the person is actually, I'm sure the person is not smoking, because they have been undergoing treatments and the likes. Lifestyle modification. Then the supplements, their supplements they can also be using. There's this oncoxin, but it's for a patient that is already on chemotherapy. There are other things the person can do. I don't know if anybody has any other contribution, they can answer that. Thank you very much.
Thank you, our presenter. Please, do anybody have any other contribution? Okay, sir.
I want to thank the presenter. I think she did very well with of advice. But although she mentioned also maybe we should explore that one. I know that this patient does not smoke.
This is not working.
But I think that supplement may be something I don't think has also been taken. Maybe we'll explore that way. Because the fear now is that maybe after surgery again, or maybe after something, it's if there is a supplement that can be, then I want it. Thank you very much for your response. And I'm still open to another person.
Good evening.
Thank you, our national chairman.
Thank you.
Please, do you still have any contribution, presenter?
Good evening, everyone. Thank you so much, our presenter, our national chairman, and also the coordinator. My name is Dr. Mrs. Aduke Akishipe, and the presentation was very educative. The case that the national chairman brought forth, we know that cancer patients are immunocompromised. And in many cases, when they are undergoing treatment, the oncologist will always tell them to stay off even vitamins and supplements. But you see that they're already immunocompromised. And this thing comes up so easily. You know, I'm not too sure whether we have these naturopathic doctors in our country. You know, it's very necessary because that also helps them to boost their immunity. Because sometimes they can't really get all the cells, even with the surgery, with the chemotherapy, radiotherapy. But if you are able to boost the immunity of that patient, it's really going to be very helpful. So, you know, such a patient, even if we don't have a naturopathic doctor, we can also, and things that supplements, whatever we can use to boost the immunity of that patient, will be very careful. Thank you very much.
Thank you, ma. God bless you. Because of our time, we'll be going to the next person. And on the roll, I can see the hand of our national half chairman in person of a farm. Please, as you have the floor, you can unmute yourself and ask your question or contribution, sir.
Yeah, thank you very much for recognizing me. I want to start by congratulating the CIPA National Chairman, the presenter, and of course the moderator for a job well done. The presentation was very, very, very educative. I just have two quick comments. The first one has to do with the prevention. That's talking about the HPV vaccine. I think we have a lot of work to do in educating or enlightening our people because the type of apathy that Nigerians have towards vaccines is actually something that is very, very worrisome. I think we need to step up our games. I have had a lot of people saying that they can never allow their daughters to take the HPV vaccine because of just no reason. So we need to step up our game in this particular direction. Then the other area is, of course, we know that prevention is always better than cure, and it's even cheaper. And if we can actually nip it at that particular stage, I think it's always better. Then that brings me to the fact that the treatment of cancer is very, very expensive. And that is what brings me to my second point, which is talking about out-of-pocket expenses by patients. The truth of the matter is that it is not all patients, irrespective of the type of cancer, whether it is breast cancer or cervical cancer or whatever, that can actually afford those treatments. And that is why most of them will prefer to probably just keep whatever the issues are to themselves. Some of them will want to go to the mountain to pray. Nobody is saying that prayers cannot work. Then some of them will want to just do some other things, go to begin to use some herbal medications that nobody knows the source and things like that. So we need to do a lot of advocacy, just like the presenter said. What is the percentage of Nigerians that are on NHIA at this particular period? You can just imagine if the kind of treatment that is gotten by people living with HIV/AIDS, if cancer patients could be getting that kind of attention, I think the burden of cancer in this country will actually be reduced. But like I said, majorly because of the out-of-pocket expenses, most of the patients in that category are not able to meet the financial burdens of the treatment. That is why most of them will prefer to just stay away. So I'm just saying that we still have a big role to play in the area of enlightening our people to change their attitude and perception towards the use of vaccines. And of course, the advocacy cannot be done alone by pharmacies. It takes everybody to be involved in the advocacy for cancer patients to be given special treatment and for their medications or whatever to be taken care of, at least a greater percentage of it to be taken care of under the National Health Insurance Act. Thank you very much for giving me this opportunity. Thank you.
Thank you, sir. God bless you for that wonderful contribution. It's actually an eye-opener and it challenges to every pharmacist of the profession. Please, the next hand I can see on the roll is Dr. Shido. Because of our time, please quickly go straight forward and unmute yourself. Ask your question or contribution, sir.
Okay, good evening, everyone.
Good evening, sir.
Okay, yeah. I congratulate the presenter. That was a good one. I'm natural medicine practitioner, homeopathic pharmacist, and a homeopathic physician. So I don't want to talk about the vaccination prevention. So let me go straight to the treatment. I have what Dr. Madu relayed about the patient. The truth is that what we need now is integrative approach to treatment of cancer patients. There is no one medical modality that is complete or that will deliver all that is needed in the treatment of cancer patients. So, for example, chemotherapy, radiation therapy, some of them are very toxic. So in as much as you're treating the patient, the patient is also uncomfortable because of the adverse and toxic effects. And we, coming from natural medicine area, we have remedies that can help manage the toxicity of radiation and chemotherapies. And if these are incorporated in the treatment, it will help the patient to cope better and have better clinical outcomes. And then for the patient that Dr. Madu talked about, the truth is that orthodox medicine has some limitations when it comes to chronic diseases. Like me, as a homeopathic physician, we know that cancer is a multi-miasmatic disease. Most times it is genetic. So because it is genetic, it's not easy to manage with ordinary orthodox medicines that's used in conventional treatment. So like in homeopathy, we have what we call constitutional remedies or miasmatic remedies that will go deep into the genetic arena and be able to reconfigure things, so that we have better clinical outcomes. So what I will advocate is that we as pharmacists should try and learn about other medical modalities. I heard somebody talk about naturopathy. Yes, that is also natural medicine. So let's learn about other natural medicine, medical modalities, so we can advise the physicians, the orthodox physicians, if they don't know, so that we can have an integrative approach to cancer management and treatment. This is my contribution. Thank you very much.
Thank you, sir. Dr. Shidu, for that contribution from another angle. And I believe that our chairman has heard what you said, and the patient will be helped. On the line, I can see from Parker. Please, you have the floor. Quickly ask your question or make your contribution, sir.
Thank you very much, sir. Sorry, my name is pharmacist Charles Akinshete.
Okay.
People call me Paka, so my phone comes up that way.
Yeah, of course, yes.
Thank you very much. A brilliant one, very lucid presentation. Thank you, pharmacists. We appreciate that. I mean, I'm very excited about oncology for one basic reason. My wife was a victim in 2008 up to 2020. And she had brain tumor, which was almost metastasized with fungal infection, with edema in the brain, in the sinuses. And she was already almost a vegetable by the time we got to know. She was admitted in Lasuth for 5 weeks. Of course, a lot of interventions and the rest, antibiotics, antifungal treatment, coupled with the proposal for surgery. But just at that point, someone introduced something to me. I won't mention names, so I don't promote a product. And we tried it. I just said, okay, fine. When I tried online, I searched and got the details. Natural, pure natural, sea nutrition. We started. Lo and behold, in less than 3 weeks, we saw great difference. So I had to discharge my wife back home. I didn't opt for the surgery. Yes, just like Dr. Ogujemio said, expensive, you need to out-of-pocket money, spend close to 2 million. But as I speak to you today, the summary is that my wife is alive and back. A lot of our colleagues know my story very, very well. So I want to align with Dr. Pharmacist Akishipe, who mentioned it earlier. It has to do a lot with immunocompromised nature of the patient. If you don't boost their immune system, there is nothing that can help them at all. So in as much as we are looking at the chemotherapy and the rest, I have a lot of patients I've been able to support. Even colleagues get back to me. Some I don't know, some I've not met before, colleagues who are involved. And this is not something people come out in the open to declare that they have it. So a lot of people, and many, 99% don't want to go for surgery, except where it is the last option. Nobody wants to go for surgery. Even doctors don't want to go for surgery. They run away from them. So there are ways, just like Dr. Chido said, integrative medicine is the way to go. There is no one cap fits all. As we speak, things are changing, and we must begin to align with it. And the question I ask, if not pharmacists in the forefront, then who? If not clinical pharmacists, then who? We should go away from the stereotyped mindset that we were taught this is the way, nothing else can work, and the rest and other things are working. Find out, extend your tentacles, you will get solution. Thank you.
God bless you, sir, for that wonderful contribution. And I believe that we have a lot of things to gain as the practice of pharmacy is, especially in this wonderful area. As I can see from Nigeria Assessment Guidelines, the latest edition, there is one important aspect that the presenter mentioned about, and I can see in the case of the last person that contributed, and also from the case of the chairman, 74, they said more than 75% of patients present late to the hospital facility for screening and diagnosis of this cancer. So I don't know which other way can there be an awareness to the society so that there can be earlier presentation. As we saw from the presenter, stage 1 is almost the stage that can be easily handled or managed. When you get to stage 4, the case is somewhere, and as the case of Dr. Madi, we've seen different things. So please, and the issue of this integrated medicine practice, I think, is an area that pharmacy profession really need to look at. And before we close, it's like I can see the hand of Dr. Shido Okoye. You still have any contribution, sir?
No,
Hello,
sorry,
sir.
no. I didn't bring down my hand. After that.
Okay. Thank you, sir. In the absence of question, please, I don't know if the CPAN National Chairman has any final note to give to the floor. Sir, if you have anything, any other thing to contribute, sir, or to say generally, you have the floor, sir.
Okay, I don't really have much. It's just that let me thank the Dr. Akinshete for his testimony or testimonial. I will still contact him later because as I speak right now, I have two different persons who are not who are cancer patients. The first one I said is the one I told her story, and she's in US. But recently I heard of another one who has also turned to vegetable, as you may say. The husband just spoke to me that the wife, who has been looking so healthy early this year, has become something else as a result of chemotherapy, and there is no much hope. So I want to thank everyone that has spoken this night, with Dr. Chido, Akinshete, Dr. Akinshikpe. Thank you very much, ma, for your input. I think, yes, when we do not have orthodox medicine to be sure of, then integrative medicine or the natural medicine, we can do that. And I also understand the issue of boosting the immune system. I really want to thank everyone that has spoken this night. I want to thank oncology pharmacists for this presentation. And I think it is a blessing already. I believe there is a blessing that we have gathered this night to listen to this topic. Most importantly, to the presenter and the moderator as well, and every other person, all the participants. As I said, it's a blessing. And I believe that it has increased our hope. I believe those people, at least those who are close to me that have learned about something about now, I can still go back to them and say, okay, maybe there is hope. Well, let us also try this. For the second woman that I was talking about, her husband told me that they have already spent, this thing is not more than 4 or 5 months now, but they have spent more than 3 million. He said that is the receipted expenditure, not the one that is not written down. And yet the wife, according to him, is not even looking good. See, all the hairs on her head are falling out and all those things. So I want to thank everyone for this. that I thank God Almighty too that we have listened to this information this night. I was actually tired, but I just have to force myself because I know that oncology clinical pharmacists, they really need to be helped. And I know that Dr. Rita Okeredia has been doing a lot of work in that department. I said, no, I must come and join that specialty group this night. And behold, I believe I have been blessed. And I know everyone has been blessed because our patients will be blessed as a result of the knowledge you have gathered this night. On that note, permit me to say thank you very much once more. And thanks for your time that I spent so much time talking. God bless us all.
Thank you, sir. God bless you, sir. God bless everybody. Please, Dr. Rita, you can give us the final note and share the grace for us. Thank you.
Okay. Standing on the already established protocol, I sincerely want to thank everyone on today's presentation for gracing it, for all the wonderful deliberations, the contributions. And I think it has been very, very impactful. To our presenter, in the person of pharmacist Temitope, you did a very, very detailed and elaborate presentation today on the burden of cervical cancer and igniting in us the very, very fundamental role we play as clinical pharmacists to try to bring down the burden of cervical cancer and in general, the predominant cancers we have in the world and in Nigeria. I thank everyone, the CPAN national members on this call, CPAN national chairman, in the person of Dr. Joseph Madu. We thank you very much, sir. The support for today's presentation has been massive. We thank you, sir. The APN chairman, sir, we also thank you. National chairman, we thank you for gracing today's clinical meeting. And to our amiable moderator, we thank you. You did a very great job today. I know that we've been very, very blessed. We have a lot of information that we can take down to every person, every woman, you know, the need for screening. They say early diagnosis is key. I know that should be our working tool as clinical pharmacists. Anywhere we find ourselves, be it in the hospital, community pharmacy, anywhere, we can go with the message, screening, early detection is key and paramount as it is. Then giving of the right information. There are so many myths going on about the vaccine. You know, I know evidence-based is very, very important. Whatever you feel you've heard or you've seen some flying everywhere is our duty as health professionals to verify, you know, instead of adding to the misconception or the misinformation as it is. So I thank everyone for joining us today for tonight's presentation. We are indeed grateful. The Clinical Oncology Pharmacist of Nigeria is grateful, and we thank everyone for joining us. Thank you very much.
Thank you, ma'am. So good night, everybody. Thank you, and God bless you.
Yes.
Thank you, ma.
Thank you.
Thank you for having me.
Yeah.
Yes, ma.
Good night.